I'm actually going to start with our commentator and our partner in this colloquium, who is Professor Daniel Béland. He is the director of the McGill Institute for the Study of Canada and the James McGill Professor in the Department of Political Science at McGill University in Montreal. His research interests focus on comparative public policy, federalism, and political sociology. He received his BA and MA in sociology from the Université du Québec à Montréal and his PhD in political sociology from the École des Hautes Études en Sciences Sociales in Paris. He's previously held research and academic appointments at Concordia University, the University of Calgary, and the University of Saskatchewan. And among his editorial board positions since 2019, he's been an editorial board member of the Journal of Health Politics, Policy, and Law. And he knows a lot about public policy. So he will be offering commentary after we're finished with the panel. Our first speaker today is going to be Amanda Aronczyk, who is a journalist and co-host of Planet Money, an award-winning NPR radio show that finds creative and entertaining ways to make sense of the complicated forces that move our economy. For all of our Canadian-based guests, NPR is the Canadian equivalent of CBC, though without the public funding, I believe, though Amanda will have to, maybe a little bit of public funding. Amanda last year contributed to the Planet Money episode Frame Canada, which investigated a decades-long PR campaign waged by the US insurance industry against Canada's healthcare system to prevent Canadian-style reforms to the US market. And I have to admit that this is where I first learned of Amanda's work when I got a snippet of that Frame Canada episode. Amanda is originally from Toronto, moved to New York in 2000, and before she joined Planet Money in 2019, she covered science and health at WNYC, New York Public Radio, and she has contributed stories to Radio Lab, On the Media, United States of Anxiety, and The Brian Lehrer Show. She was also the lead reporter on the award-winning radio companion series to the PBS Ken Burns documentary, Cancer, the Emperor of All Maladies. Amanda also teaches at the Newmark Graduate School of Journalism at the City University of New York, and we're really, really delighted that Amanda was able to make time in her day to talk to us. And then following Amanda, we're going to have Gregory Marchildon, who is the Ontario Research Chair in Health Policy and System Design with the Institute of Health Policy, Management and Evaluation at the University of Toronto. He previously was the Canada Research Chair in Public Policy and Economic History at the Johnson Shoyama Graduate School of Public Policy. Professor Machido received his PhD from the London School of Economics and later served for 5 years at Johns Hopkins University in the School of Advanced International Studies in Washington, DC. In the 1990s, he was Deputy Minister of Intergovernmental Affairs and subsequently Deputy Minister to the Premier and Cabinet Secretary in the government of Saskatchewan. So we have a real Saskatchewan contingent here, I'm excited to note. From 2001 to 2002, he was Executive Director of a Federal Royal Commission on the Future of Healthcare in Canada. Some of you might know it under the title the Romanow Commission. And he's the author of numerous journal articles and books on Canadian history, comparative public policy, public administration, and federalism. He is also the founding director of the North American Observatory on Health Systems and Policies. I realized that was a lot to share with all of you, but I wanted you to know what a really amazing panel we have today. I also want to recognize the financial funding of the Canadian Consulate in San Francisco that supports our colloquium series. And I want to thank everybody who donated during our Big Give campaign. The Canadian Studies program at UC Berkeley is funded by over 80% of private donations, either past donations that we continue to draw on or present gifts. We are not supported very much by the university, unfortunately. And so for all of those of you who have made donations in the past, I thank you. I sort of feel like I'm doing an NPR sponsorship here too. I think without further ado, we are going to turn over to Amanda, who is going to talk to us about this Frame Canada campaign. And maybe I should just say that what we're planning to do is we're planning to have presentations of about 15 to 20 minutes for each of our speakers. Danielle will then offer some commentary, And then we're going to open it up to questions from the audience. Because we're a big audience of about 67 people, I'm going to ask people if they can to please chat their questions. And you can do it either directly to me or to Tomas, and then we will read out those questions when we get to our Q&A period. All right, Amanda.
Hello, everyone. Can you guys hear me? Maybe somebody could nod. Perfect, thumbs up. And I guess if you can put up the slideshow, that would be great. I can go through it pretty quickly because your introduction was so good. So I just want to say, first of all, I'm super happy to be here and to get to talk about this episode. This is like one of my favorite episodes ever because it answered this question that I had since I moved to the United States in 2000. So this was like, I really enjoyed making this. Next slide. So I covered health and science for WNYC. Are you able to move to the next slide? Am I the only one seeing? I assume we're seeing the same thing. It's not a big deal. It's just more like fun things to look at. There we go. Excellent. Okay, so I actually I covered science and health for about 5 years, and I didn't, in fact, really cover healthcare, but healthcare, of course, touches all of these topics. So, I did this project about healthcare in the Bronx, in New York, and a series about cancer with PBS. And then I also did, in 2018, I did a whole year on this project called Germ City, which asked, how do contagious diseases and pandemics shape cities? So we all know the answer to that now, but it definitely was like, my timing was a little off, but I was, we were getting closer. I learned a lot. Next slide. Hopefully, I have some audio to play for you, so hopefully that will work too. We will see. So now I work for this American show called Planet Money. We cover business and economics. And when I moved to the US, I found American healthcare to be like the most mysterious thing. For the first year that I lived in New York, we didn't have healthcare at all. And which was its own sort of adventure. And then after about a year, we did get coverage. And I remember in those early years, every year I would call my healthcare, like my health insurance company, and I would say to them, like literally in tears, I don't understand why I'm still paying for everything. So, you just pay and pay and pay. And years later, I could look back and be like, I hadn't hit my deductible. So that's why, but it was just so confusing. And people in the United States don't understand that it's confusing because everybody's used to it. So even when I would call the insurance company, they were a little bit unable to explain it to me because they didn't understand how confusing it was to an outsider. So in that first year that I lived in New York, I went to a park in Brooklyn and I sat down on the grass and something bit me, which was unfortunate. And instead of just going away, the bite got worse. And I had to go to the doctor. And so this would prompted all these conversations with my friends and with colleagues and whatever about like going to the doctor and what that meant. And I would talk to people about it, and Americans would say to me just like the strangest things that I just didn't understand it at all. They would say to me, at least you're in the United States, it's much better than Canadian healthcare. Canadian healthcare is so bad. So that was kind of like assumption number one, is they would say that Canadian healthcare is terrible. They would also say that Canadians wait forever. Like they'd heard this, they'd been told this, that Canadians wait forever to get treated for everything. You're always in a lineup for something. And then the third thing, and I remember people saying this to me because it was kind of vivid, was that they would say Canadians die lying on a gurney in the hallway of the hospital. That was like a thing that like happened to Canadians like all the time. And I just remember, and very like this was people that I knew and respected would tell me these things about Canadian healthcare. And I just was like, I don't really understand where you guys are all getting this from. And this, I would hear this regularly. And so this past summer, I guess it would have been now, not 2020, maybe 2019. What's the date on this? Yeah, no, so this past summer, 2020. Sorry, I lost a year. I was reading Twitter and I came across this article, which you can see here, which was the healthcare scare. I sold Americans a lie about Canadian medicine, and now we're paying the price. And it was written by the photo of the man you see. His name is Wendell Potter. And he'd also written a book, which is the other thing up there, Deadly Spin. But this was an article where he really specifically, oh, hold on a second, sorry. Of course, I'm just logged into Zoom in a different way than I'm used to. And so, oh, there we go. I just timed out for a second. I'm back. So he just focused on this Canadian thing. And so I called up and I was like, I need to find out from you, like, what you're talking about. And we were able to tie together all of these different pieces of Wendell Potter's career working for various American health insurance companies. So he started, I forget which company he worked for, Humana, I think originally, and then he was at Cigna Health Insurance for a very long time. And he ran the PR department for Cigna. And he has since become a whistleblower, which is what that book is about. So he's kind of turned against health insurance industries and sort of speaks a lot about the problems with it and about Medicare for All. And he set up his own kind of like, wouldn't call it a think tank, but like his own sort of group. Anyway, so part of his job, it became clear when we talked about it, was to run campaigns that would specifically badmouth Canadian healthcare. Because one of the biggest fears of healthcare companies, the healthcare industry in the United States, is that Americans would discover that just to the north was this country that had basically free healthcare and also better health outcomes. So next slide. I started to trace with Wendell kind of like different moments in time where these arguments had come up. Wendell started working in the healthcare industry around 1992, and that was the same year that you're looking at George H.W. Bush. This is Bush Sr., the father, and he was running for re-election against a young Bill Clinton that year. And what you're going to hear, hoping that the audio works, is an excerpt from our Planet Money story. Don't play it quite yet. Give me 1 second. And you're going to hear George Bush Sr., and you're also going to hear Robert Smith, who's one of the co-hosts of Planet Money, who also happens to be Canadian. I'm from Toronto. He's from London, Ontario. So we had a really good time writing this together. So what you're going to hear is George Bush on the campaign trail in 1992, and he's arguing that the Democrats have very dangerous ideas about reforming American healthcare. See if it works.
And then there's another favorite Democratic plan. To make the federal government the monopoly provider of national health insurance. And if you think socialized medicine is a good idea, ask a Canadian for a second opinion.
No one actually asked me at the time.
They didn't ask me either.
But I totally could have answered. In Canada, healthcare is just a normal thing that the government runs, like schools.
So then in the episode, Robert and I go and we explain a little bit about Canadian healthcare. And what the Clintons were actually proposing back in 1992 was not, in fact, universal healthcare or even anything like Canada's system, but they had borrowed a couple of ideas. And Wendell explained that the whole industry was very unhappy about the Clintons' proposal. And this meant big pharma, this meant health insurers, this meant hospitals. And so all of a sudden, he found himself in a situation where these kind of three big entities who don't usually get along very well and don't usually like negotiate or sit at tables together, all of a sudden had a common enemy, which was the Clintons. So so they start what is kind of like a lobby group. It's called the Healthcare Leadership Council, and they represent all these different groups. And they agree that when they talk about Canadian-style healthcare, that they're going to like have some specific language that they want to use to sort of denigrate it. And so they decide to call it government-run healthcare, which in the United States, if you are American or if you live in the United States, calling something government-run is usually kind of a negative. And if they wanted to make it sound like a little bit worse, they would call it bureaucratic-run healthcare. And then really, if they were like really going to go after it, they were going to call it socialism. Like does not fly here. So I found all of this incredibly interesting because I had no clue that those things that people had told me about what they understood about Canadian healthcare had actually been part of like a coordinated campaign that had kind of come and gone for many, many years. So next slide. And it basically comes up every time people are debating healthcare. So in the next slide, you're going to see Obama. Let's see here. I think you got it. There we go. So flash forward a couple decades, and it's not like Wendell Potter is like involved in all sorts of things. First of all, he does all sorts of other things with the health insurers. This Canadian slamming Canada thing was just like one piece of a larger job that he had. But the Canada thing obviously comes up whenever anybody talks about reforming American healthcare. So flash forward a couple of decades, Obama is running for president, and he's trying to make what would become known as the Affordable Care Act a reality. So again, if you could play the audio, that'd be great.
Thank you.
13 years later, Barack Obama decides to run for president.
Thank you.
And there he is, starting the same fight as the Clintons tried.
I will finally keep the promise of affordable, accessible health care for every single American.
At that point in time, Wendell is working for an insurance company. He's working for Cigna.
Our internal polls showed us that a majority of Americans were favorable to the idea of a Canadian-style healthcare system, and that scared us to death.
So that is the sound of Wendell Potter's voice, by the way. He's the last voice that you heard from there. And his point is that Canadian healthcare gets cited over and over again, basically anytime Americans are debating and discussing healthcare. And it's always sold as something that you do not want. And so they're disparaging it in, advertising campaigns. And one of the things that they do is run a campaign, which is a real term in marketing. It's called a FUD campaign. And that's that you lean into FUD, fear, uncertainty, and doubt. So it's not that you even have to sell something or give a lot of data points or whatever. You just have to make people scared about something. And so Wendell helped organize campaigns that would make people scared of the prospect of Canadian healthcare. So, during my conversations with Wendell, one of the things I brought up with these gurneys, all the Canadians, the billions of Canadians dying on gurneys in the hallways of hospitals. And I couldn't believe it. Wendell was like, oh, yeah, I remember, I had a bunch of photos to go through. And I remember that gurney photo. I remember helping pick that. So that was a little shocking to discover that was a real thing. That wasn't just some random thing that my friends and colleagues had heard of. That was a real piece of a campaign. And not only was it a piece of a campaign, but it was it had slipped into the public's unconscious, it had worked. What Wendell was doing, Wendell was doing a good job, and the people that he worked with were doing a good job on this massive campaign. So Wendell, realizes how effective this all is, and he remembers, watching the Senate or different discussions or debates around healthcare, and he would hear things that he had written, talking points come out of the mouths of senators and representatives when they would debate healthcare. So now, he couldn't just come up with things. As you might imagine, these anti-Canadian healthcare ideas have to come from somewhere. So Wendell said that when he was working in PR for insurance companies, he would need data and he would need research. He'd have to cite something, especially if he had talking points that he was sending to senators or whoever. And one of the people that he would go most often to was a woman named Sally Pipes. So if you can go to the next slide, that would be great. And this next clip starts with an excerpt from the Mark, I'm going to say his name wrong, Levin show. I think it's Mark Levin. And this is a conservative talk radio show. If you can play the audio, please.
Hello, America. I'm Mark Levin. This is Life, Liberty, and Levin. We have a great guest, Sally Pipes. How are you?
Fine, thank you. Nice to be on with you. Sally Pipes is also a Canadian who walks among us. She's lived in the U.S. for a few decades.
Sally Pipes, you're President, Chief Executive Officer of the Pacific Research Institute of San Francisco-based.
And she's in the media all the time.
We have no idea what they're talking about, do we?
Well, I think I do because I'm a former Canadian who grew up under single payer.
She's a go-to person because she, by mentioning that she's from Canada, she will often talk about her mother.
I'll just tell you a quick story about my mom, who passed away in December 2005.
And how can you dispute that? If she's talking about her mother or her sister, it's, you can't counter something like that.
And, that's just an anecdote. She was using anecdotes, but her think tank that she is the president of and has been running, I think, since the 90s, is a ton of research and data. She's in the media all the time. She's got regular columns. You can see her books down there as well. And when Wendell was working for doing PR for insurance companies, he would rely on her and he would rely on her institute and her research to make arguments about how bad Canadian healthcare was. And I did not, unfortunately, have enough time working on the story to really dig deep into all of the funding that Sally Pipes Institute gets. So if anyone's looking for a research project, there is some information out there already, but there's more to be found, I believe. So there's a lot of money coming in, and there's a reason why she denigrates Canadian healthcare. Oh shoot, sorry guys, when I don't touch my computer for long enough, it freezes on me and then I can't see you guys anymore. I just assume you still hear me. There we go. Okay, there we go. If nobody's saying anything to me, I'll assume you guys can still hear. So she is very prolific, and she, as you heard, she uses anecdotes, and she's got a lot of data, and much of the data comes from real things. So like she might go look at something very specific, like the wait times for knee or hip replacement surgery in Canada, which is longer, I believe, than the United States. But then that sort of detail will kind of get used to sort of say, well, Canadians are waiting for everything. And they'll sort of bury the fact that that might be an elective procedure. And the implication, pardon me, is that Canadians are like waiting for like heart transplants or whatever, and therefore dying on the gurneys and hallways. And the thing that I find sort of interesting about Sally Pipes is that, you know, I did a story years ago about the PR campaigns around climate change, and I'm sure you've heard of Merchants of Doubt and the book and the documentary and stuff. And there's like a lot of people who were kind of involved in that kind of PR campaign. And in this case, I think there's Sally Pipes. She is kind of a one-woman band of providing information, because most people, Americans, don't necessarily care what Canada is doing, but they will look to it once in a while when these debates come up, and Sally is there ready and willing to sort of talk about it and pull out all sorts of anti-Canadian healthcare stats. What was I going to say? I think I'm just coming to my conclusion here. I think Wendell's point, and it was very interesting to talk to somebody who was like on the inside of this, was that, you know, Americans debate and discuss healthcare like periodically. It's not like a constant thing, right? It sort of comes up at different moments in time, especially when people are running for election stuff. And this playbook of tactics hasn't actually changed that much since the early 90s, when he was starting to help sort of write this playbook. But it gets pulled out time and time again when people, especially in the United States, talking about like Medicare for all or universal health care, and everybody looks to Canada and goes like, is that something that we want? And then the answer is no. And this playbook that Wendell Potter helped write gets pulled out again. And according to Wendell, he believes the same playbook will get pulled out again the next time this conversation gets opened up in the United States. So that's pretty much my talk. I have my last slide. I put up my email and my Twitter account if that's something, if you guys have questions or anything like that. And I hope that was of interest to you. And it sounds like I will be able to take questions from everybody, but not yet, right? And then they'll happen later in the chat. So thank you so much. I hope that this was of interest to you.
Thank you so much, Amanda. I thought this was absolutely fascinating. I believe that we have finally worked a workaround in terms of our other speaker. We have a 306 area code, so continuing into our Saskatchewan theme, I'm going to welcome Gregory Marchildon to our seminar. And I am actually, Tomas, I am going to cue the PowerPoint because I have it on my computer. And Greg, I am going to do a share screen, and then you can start chatting with everybody, and you're just going to have to tell me when to change slides.
Well, thank you very much. Can everyone hear me okay?
We can hear you very well.
Okay, that's wonderful. Thank you. Well, thank you very much for the invitation. I very much apologize that I can't be there visually, but hopefully I can try to make up for it with my voice, which I have sometimes trouble projecting. So if you find that you can't hear me, please stop me, and I will try to be a bit louder. So I've been asked to talk about what the US can learn from the Canadian model of Medicare. And what I came up with, and you can see this on the next slide, are in fact a number of lessons. I picked out 6 lessons. And these lessons in terms of universal health coverage are probably more generalizable than just in terms of Canada. but I'm going to put them in the Canadian context. And the first is that universal health coverage is definitely achievable despite the many special interests that will fight it from its inception through its maintenance. The second principle is that the strong form of universality maximizes public support and loyalty. And I think that the stronger the type of universality you have, the more in which you can maximize public support and loyalty. The third lesson is that innovation and leadership can come from the and should come from the subnational level. And that is that provinces in Canada and states in the US can play a very important role and should. The fourth lesson is that the federal government should nonetheless have a key directional role and a role in standard setting that is critical. And the fifth lesson is that cost control is essential for long-term sustainability of universal health coverage. And the sixth is that you not only attain better access through universal health coverage, but the experience is that you can achieve higher levels of quality and better outcomes in terms of population health. So I'll go through each of these fairly quickly. First, that universal health coverage is doable despite opposition. And here in the slide, I've got a sort of a chronology of how universal health coverage was introduced and then maintained in Canada. And as you can see, it occurred over an extensive period of time. I want to draw your attention to 1962, when universal medical care insurance, as opposed to hospital insurance, was first introduced in the province of Saskatchewan in 1962. There was widespread opposition, in particular from professionals in the business lobby, and there was a 23-day doctor's strike. It didn't end there. The opposition continued for some time, and that there has always been an effort to try to bring down the system of universal health coverage in the country. And there has been significant debate about whether universal health coverage should be expanded or, in fact, it should be more restricted. The courts have recently been involved in the latest case, Cambie Surgery's case. The Supreme Court of British Columbia decided, in fact, that that there could not be private health insurance that could compete with public health insurance, that was not a legitimate demand on the part of the litigants that brought the case. And so we continue to be involved in a situation in which you have the majority of the Canadian population in favor, but powerful interests, very vocal interests that continue to try to figure out ways in which to bring the system down. Next slide, please. The next thing is that I want to emphasize that universal health coverage is only one layer in the Canadian health system. And so when I talk about universal health coverage, I'm talking about that first layer of public services where all that receives a complete public funding. Now, the coverage package for this is fairly narrow. It's hospital and physician services, basically primary care, as well as medically necessary diagnostics. It may be narrow, but it's also very deep in the sense that there are no user fees in terms of acting as barriers to coverage. And it's fairly comprehensive in terms of that narrow basket of services. Next slide, please. And now we'll move to the second lesson, which is strong single-tier universality as we have it in Canada. That means that, and I'll go through the elements of it. The first element is there's a comprehensive public coverage package As I said, it's narrow but deep. But this means that private health insurance in the Canadian context is either prohibited or discouraged for that same set of services. There is no separate private delivery tier. All Canadians have a right of access to the same set of services and facilities. There are no private hospitals and there are no public hospitals in that sense. Whatever their ownership structure, they offer services to everyone in the country. The next characteristic is that there's really no private release valve within Canada because there's no parallel private insurance system or private set of services. You would think that this would generate a fair amount of demand for services in the US by the very rich in Canada. In fact, travel to the US is very limited. And of course, it's only to access the very top tier of the US system, whether it's the Mayo Clinic or it's Johns Hopkins or some other similar university-based system. The last point I want to make here is that the choice of having a single tier, and I call it strong universality principle, is basically a value choice. And here Canada is very consistent with the Nordic countries, but different than other countries such as the UK and Australia, where you do have at least a small parallel system. This is also probably not consistent, at least with some values in the US. And so there may be continuing demands, at least in some parts of the United States, for this kind of two-tier or multiple-tier services. In other words, demands for economy class, business class, and first class, something which is avoided in Canada and the Nordic countries. Next slide, please. And this is really governed in part through the Canada Health Act, and I want to draw your attention to the Universality Principle, which is Section 10 of the Canada Health Act, which ensures entitlement to universal health coverage on what is termed uniform terms and conditions. No business class, no economy class. In other words, they all have to be the same terms and conditions. Next slide. So the third lesson in terms of Canada's model of Medicare is that there are some clear advantages to living in a federation, in particular innovation at the provincial and the state level. And there's a real opportunity, in fact, to learn from subnational innovation and experiments. We saw that in terms of Saskatchewan in the creation of first universal hospital coverage in 1948 and then universal medical care coverage in 1962. We've seen that in terms of the influence of the Massachusetts system that was created in terms of the Affordable Care Act. It was very much based on that multi-payer system of universal health coverage. And looking forward, you can see that this could occur through other jurisdictions. Right now, I'm talking to various individuals from California and some possibilities in terms of new legislation, a new approach, and perhaps even a single payer approach. That's why I show the state capital of California here. In a federation, when you have successful subnational experimentation, of imitation, adaptation, and spread throughout the federation. But you can also ensure that if you have, in fact, policies and programs that are poor or that fail, you can limit the damage by the fact that you do not imitate and adapt those programs. The other advantage is that, of course, provincial and state governments are closer to the population being served than the federal government, and this has very distinct advantages. And finally, you can manage and better satisfy political diversity. This is a real issue in Quebec, where we have provinces such as the province of Quebec, which is very different than other provinces in the country from an ethno-linguistic and political standpoint. And this offers the latitude to basically pursue policies that better fit the preferences of their population. Next slide, please. The fourth lesson is that despite the importance of this subnational innovation, leadership, and experimentation, federal government leadership remains essential if you're going to have a coherent system of universal health coverage. And in fact, the federal government is absolutely critical in encouraging either the establishment or the expansion of universal health coverage. And I mean this in terms of its three dimensions. Not only in terms of population, where you're trying to achieve up to 100% coverage, but also in terms of the health services that are part of your basket of coverage. And initially, in fact, it is naturally the state that you can't cover everything. But if you have a plan that over time you're going to progressively bring in new services into your basket of coverage, that's generally the way in which universal health coverage works in most countries. And so it's not so much a destination, because no one in the world, no country in the world has universal health coverage for 100% of health services, but it's an aspiration. The final aspect or characteristic of universal health coverage is the depth of coverage, and that is progressively removing financial barriers. Of course, in the case of Canada, we decided basically from the beginning not to have user fees and these kinds of financial barriers. The other reason that the federal government is essential is because of the need to have common design features and some national standards. And these are incredibly important in any federation. These are often very high-level principles, and they often require and basically can only exist with the federal government's direct leadership. The federal government is also there to ensure the portability of coverage across provinces and states. And that too is essential in an effective system of universal health coverage. And then finally, to provide the funding, if not the agencies, for research, information, and data, as well as funding and the appropriate amount of evaluation of innovations and their comparison across the Federation. Next slide. And you can see this in terms of how the Canadian health system is organized. You can see the federal government's very strategic role. It is not important from a funding standpoint. It only provides something in the order of about a quarter of the funding for all healthcare in Canada through its tax funds, but it's absolutely critical in its strategic role, and you can see that through the Canada Health Act. You can also see it through federal participation in the ministers' conferences and committees, and you can see it in terms of the creation of various agencies at the federal level. Next slide. The need for cost control for long-term sustainability is the fifth lesson from the Canadian system, which has been very good at controlling administrative costs and overhead from the beginning. And based upon data from 2017, it was found that Canadians pay 80% less per capita than Americans on administrative overhead. Now, this administrative overhead may represent jobs, but it is also, as economists would say, a deadweight loss. every universal health coverage system has to impose some discipline on provider costs. This is what we try to do in our single payer systems with mixed success. And if you're in a multi-payer universal health coverage system, you have to impose discipline on insurers in order to control costs. Now, all systems ration. And at the two extremes, they either ration through ability to pay, or at the other end of the spectrum, through medical urgency. And in Canada, it's medical urgency that determines your position in the queue. But of course, this does create wait times, not only in Canada, but in other countries that are similarly structured for non-urgent procedures and tests. And this is an area that has given much fodder to propagandists in the US who argue that the Canadian system is a failure. At the same time, it requires political will to use the mechanisms at your disposal. And in fact, Canada has not been particularly good at fully exploiting the single payer mechanism for cost control. This was pointed out a few years ago by my old friend, Uwe Reinhardt, who wrote about this at length and also was a regular commentator and analyst of cost control in the United States. And in his view, Canada had really missed an opportunity by not using the single payer mechanism more effectively to exercise greater discipline on provider costs. And the reason that this has not happened is because provincial governments have been very much intimidated by the power of, in particular, the medical profession, number one. And number two, we operate in a high cost environment where health providers, particularly physicians, but also others such as nurses, have to be paid extremely well in order to ensure that they don't move to other jurisdictions, especially the United States. Next slide. The sixth and final lesson is that universal health coverage achieves better access and quality. And here I'll use something called the Health Access and Quality Index, which is an aggregate measure of health system performance focusing on the access to, as well as the quality of healthcare interventions. And it looks at avoidable deaths in 30 disease or condition categories across almost all countries in the world. And it looks at how well every country does on each of the conditions. The scale then is the aggregate result with an index of 0 to 100. The closer to you are to 100 on the Health Access Quality Index, the better your health system performance. The more deaths you're avoiding through the quality and effectiveness and timeliness of your health system. And as you can see here, Canada is well in the top 20 of countries. It's currently at position 14 based upon the last results. Its actual number on the index is quite high, but you can see that the United States is reasonably low, in fact, quite low at 29th, with an HAQ index of 89. So you can see there's quite a profound difference. And you can also see that you might be surprised by some of the results in that Germany, France, and the United Kingdom are fairly low, despite their fairly high rankings in the Commonwealth Fund surveys. So this is a very good counterpoint to the Commonwealth Fund data. Next slide, please. So now let's look at it in terms of population health outcomes. And here again, we plot health expenditures against life expectancy, and you can see how poorly the United States does relative to Canada. Now, Canada does a bit better than Germany, the Netherlands, Belgium, but it's very much it's sort of in the middle of countries. It's not that it's doing extremely well. It's not like Japan, but it's doing pretty well. And part of the reason is Canada exists in a high, what I call cost area, simply because of geographic position vis-a-vis the United States. Expectations of the population are extremely high, so you have a demand for the very best, and you have to pay for that. But even with that, Canada does remarkably well. Next slide. So I'll end on this in terms of some ambitious hopes for the future for both Canada and the United States. And here I just want to emphasize in terms of Canada that this agenda that I put forward is one of moving forward to increase universal health coverage over time, in particular bring in outpatient prescription drugs, deal with long-term care, and to deal with the wait time problem for elective surgeries. In the United States, here I'm going to be a little more speculative, but with the Biden administration moving beyond the Affordable Care Act to allow states to experiment, but to really encourage single-payer experiments in some states, despite the fact that the ACA is a multi-payer model, but to allow the flexibility for a single-payer model to emerge, at least in some states. To more strictly regulate and to allow states to more strictly regulate the multi-payer arrangements that they may want to keep, if some of them want to keep those arrangements. The next thing is to allow for not just voluntary enrollment, but compulsory enrollment. In other words, reintroduce the mandate in a much more muscular way. And finally, the hope that someday there may be litigation in which the courts in the U.S. eventually rule that access to medically necessary health care is a basic human right. So on that, I want to thank you all for your patience.
Thank you so much, Greg. And we heard you perfectly, despite the unorthodox way that we just did that. That was fascinating presentation. Given that we have had our technical difficulties, I'm going to invite Danielle to maybe give some brief remarks so that we can then get to some more questions and comments. We've had a lively chat going on between some people who seem to have had a lot of experience and thoughts on healthcare, but right now I'm going to turn it over to Danielle.
Thank you very much, Irene. And first of all, also, I want to say that I'm really glad that the McGill Institute for the Study of Canada and Canadian Studies program at Berkeley have this joint event today. And this is not the last joint event, I hope. And I hope to see you in Montreal at McGill on campus, hopefully in a year from now or less. You're invited to come to visit us. Look, these are great presentations. I want to, and I could comment on them in a specific way, but let me flip the narrative a bit and let's talk about how Canadians perceive the US healthcare system. And many Canadians, and it's maybe less the case today as it was maybe a few decades ago, but have defined their identity in part in relationship to healthcare, having access to universal healthcare, something that makes Canada distinct from the US. But not from the rest of the advanced industrial world. And the thing about the United States is that the healthcare system that you have in the US is unique among rich democracies. And so, of course, there is a book by Antonia Baioni, our dean here at McGill, called Parting at the Crossroads, and showing how the US and Canada in the 50s and 60s took two different paths in terms of health insurance. But what's interesting is that the path that the US has taken in retrospect is quite unique. As I mentioned, the fact, for example, that you have a program called Medicare for people aged 65 and older, and later it was extended to people with disabilities. This is something unique among rich democracies, that you started to target the most vulnerable group, older people, and later on people with disabilities, with a purely federal program, which actually may have decreased the momentum for universal health insurance because you covered the most vulnerable people first. What's interesting when you look at the US today is not only that the system is really unique compared to other rich democracies, which all have in a way or another universal coverage. Even Switzerland, which is closer to the US model, which central role of private insurance, but still universal coverage. Something that's also quite peculiar about the US is that many people are not necessarily aware of the central role that the government plays in healthcare. I remember in 2009 during the town halls meeting in the US when there was debate about Obamacare, how many older people, especially people who were against Obamacare, what will become Obamacare, the Affordable Care Act, they said, don't touch our Medicare, and government hands off Medicare, like if Medicare was not a government program. And this is related to the fact that the US healthcare system is extremely complex, much more complex than the Canadian system. And this imbrication of public and private benefits and actors makes it very, very hard to understand for ordinary people and even for experts, frankly. It's a very opaque system. And this is related to what Andrea Campbell and Kimberly Morgan call the delegated state, when government often will reimburse private providers and when private actors would deliver public benefits. And that becomes so very complex. When Americans look at Canada and you see the spin doctors, spin doctor is a good term here that Amanda was talking about, these people are trying to simplify the Canadian system, which is easier to understand than the US system, but they simplify it to a way that is cartoonish, obviously. Sometimes they take things that are true, that yes, sometimes we have waiting lists for some elective surgeries. And as you said, Amanda, they use these factoids and then they generalize in a way that doesn't make sense. But Canadians have also misconceptions about US healthcare. And that's important to understand that. I think that in the US, if you have a very good private insurance, you can get some terrific, wonderful healthcare if you have the money for it. The problem with the US system is that it's really unfair and it's also extremely expensive. But they are, in Canada, we talk a lot about the US when we talk about healthcare, because people who oppose a greater role of privatization or private actors within the system, they all use the US as a negative example, an example that we should not follow. So we frame the debate as we are not the United States and we don't want to be like the United States in terms of healthcare. But there are some people on the right who actually are sympathetic towards the healthcare system, like people at the Fraser Institute and libertarians. And there is a movie that, for people who like Canadian movies or are interested in it, for those who have watched Barbarian Invasions, the movie by Denis Arcand won actually the best foreign language movie back in 2004 in Academy Awards. It depicts a very, very negative image of the Canadian healthcare system. And it's a movie filmed in Quebec, here in Quebec, and it's very gloomy. And actually, people at the Fraser Institute, when they saw that, and some people in the US say, see, this is the Canadian healthcare system. It's so bad, so inhumane. And there's this scene in the movie by Denis Arcand, and you should watch it again. It's a great movie, Barbarian Invasions. I really love it. There's a scene where this Canadian patient, goes from Quebec to New York State. He travels by ambulance to receive some care in the US because he cannot receive care in Canada. And then the doors of the ambulance open, I think at the border and the back, and then he sees the US flag and it's like, oh, I'm saved. So anyway, there is a debate about healthcare in Canada too, and the US is often very much present in our mind when we discuss the future of our system. Our system has many flaws. We saw it during COVID-19, long-term care facilities. The long-term care system faces a lot of challenges. It's underfunded. We saw how many older people died in Quebec, in other provinces in long-term care. We have a problem with pharmacare and coverage in terms of pharmaceutical coverage and so forth. So there are many challenges here in Canada. But when we talk about healthcare reform, the US is never far behind in terms of you know, we always compare ourselves with the US. We are obsessed with the US. We think much more about you guys than you think about us. My wife is from San Antonio, Texas. I can tell you most people in San Antonio, they don't care much about Canada, right? People closer to the border, perhaps. But what's important is that we always, there is a strong tendency in Canada to frame our healthcare debate in relationship to the US. But sometimes it can become too binary a logic, because we need to look at what's happening in Europe, in Japan, in Australia, and New Zealand, look at other countries, because the US is so unique, so particular, and not always in a good way in terms of healthcare, that comparing yourself with something that no other countries is really doing, it might skew the debate in a way where you're afraid of change because you think if we change a little bit, we'll become like the US. And that is perceived as a nightmare scenario for many people, especially on the left. So there are some advocates of a US-style system in Canada, but they form, I think, a relatively small minority. But people who tend to defend the system as it is, they will refer a lot to the US as this kind of monster, the poster child of what we don't want to become. So that's the kind of flip side of the story that Amanda is talking about. Thank you very much for your two presentations, very enlightening. And of course, now we'll take questions, and you're back. I think you're back to your role as moderator, Irene. Thank you very much.